Input 6, acute viral hepatitis. Viral hepatitis, background. Systemic infection affecting the liver. Almost all cases are caused by one of 5 viral agents. Hepatitis A virus, HAV. Hepatitis B virus, HBV. Hepatitis C virus, HCV. HBV-associated delta agent or hepatitis D virus, hepatitis E virus, HEV. Hepatitis A. What is the A? Genetic material? Single-stranded positive sense RN. A. Incubation period. 14 to 28 day. Replication is limited to the liver, but the virus is present in the liver, bile, stools, and blood during the prodromal and ictery. When do you expect shedding in faces, viremia, and infectivity to diminish? How do you diagnose hepatitis A? Serologic testing IgM anti-Ha. V. How would you demonstrate immunity? Presence of immunoglobulin G, IgG, antibodies against hepatitis A virus, HAV, hepatitis B, DNA virus, complex genomic structure. Hepatitis B. HBsAg particles remain in the hepatocyte. What is the qualitative marker of HBV replication and relative infectivity? HBsAg positive and anti-HBc positive. Serum is more likely to be highly infectious and to be associated with the presence of hepatitis B virions and detectable HBV DNA than HBe negative or anti-HBe positive serum. Early during the course of acute hepatitis B, HBAg appears. Transiently its disappearance means what? What if it persists? And what will detectable levels imply in such state? What is the first virologic marker detectable in the serum? Precedes elevations of serum aminotransferase activity and clinical symptoms by 2-6 weeks. In typical cases, it becomes undetectable 1-2 months after the onset of jaundice and rarely persists beyond 6 months. After it disappears, antibodies becomes detectable in serum and remains detectable indefinitely thereafter. In some persons, years after HBV infection, anti-HBc may persist in the circulation longer than anti-HBs. Therefore, isolated anti-HBc does not necessarily indicate active virus replication. Most instances of isolated anti-HBc represent remote resolved HB. V. Infection with immunity. But it may also mean continuing infection with low-level viral replication. HBAg appears concurrently with or shortly after HBsAg. Its appearance coincides temporally with high levels of virus replication and reflects the presence of circulating intact virions and detectable HBV DNA. In chronic HBV infection, HBsAg, positive. Anti-HBc, positive. Anti-HBs, negative. During early chronic HBV infection, HBV DNA can be detected both in serum and in hepatocyte nuclei, where it is present in free or episomal form. This replicative stage of HBV infection is the time of maximal infectivity and liver injury. What is a qualitative marker of this stage of infection? What about quantitative marker? Over time, the replicative phase of chronic HBV infection gives way to a relatively non-replicative phase, at a rate of 10% per year, and is accompanied by seroconversion from HBe positive to anti-HBe positive. Hepatitis C. At least 6 distinct major genotypes. Intragenotypic differences are referred to as quasi-species and differ in sequence homology by only a few percent. Hepatitis E. Previously labeled epidemic or enterically transmitted non-A, non-B hepatitis. Enterically transmitted virus that occurs primarily in India, Asia, Africa, and Central America. Viral hepatitis, pathogenesis. Largely non-cytopathic. The impact of the virus is mainly due to the host's immunologic response. Hepatitis B. the existence of inactive hepatitis B carriers with normal liver histology and function, and patients with defects in cellular immune competence remaining chronically infected rather than being able to clear the virus, leads to what clinical implication? Precore genetic mutants of HBV have been associated with the more severe outcomes of HBV infection. How does HBV acquired at birth differ from HBV acquired during adulthood? Hepatitis C. Cell-mediated immune responses and elaboration by T cells of antiviral cytokines contribute to the containment of infection and pathogenesis of liver injury associated with hepatitis C. Viral hepatitis, extrahepatic manifestations. Occasional serum sickness like prodrome in acute HBV. Other types of immune complex diseases may be seen in chronic HBV. Essential mixed cryoglobulinemia, EMC, is another extrahepatic manifestation. How is it characterized? Viral hepatitis, panlobular infiltration with mononuclear cells, hepatic cell necrosis, hyperplasia of Kupffer cells, variable degrees of cholestasis. Hepatic cell regeneration is present, as evidenced by numerous mitotic figures, multinucleated cells, and rosette or pseudoacinar formation. Bridging hepatic necrosis. Subacute or confluent necrosis or interface hepatitis. More severe histologic lesion observed occasionally in acute hepatitis. Bridging between lobules results from large areas of hepatic cell dropout, with collapse of the reticulin framework. Viral hepatitis, incubation periods. Hepatitis A range from 1545 days, mean, 4 weeks, hepatitis B and D from 3180 days, mean, 8-12 weeks, hepatitis C from 15160 days, mean, 7 weeks, hepatitis E from 1460 days, mean, 5-6 weeks. Signs and symptoms. Prodromal symptoms are systemic and variable. Constitutional symptoms of anorexia, nausea and vomiting, fatigue, malaise, arthralgias, myalgias, headache, photophobia, pharyngitis, cough, and coryza may precede the onset of jaundice by 1-2 weeks. Nausea, vomiting, and anorexia are frequently associated with alterations in olfaction and taste. A low-grade fever between 38 degrees and 39 degrees Celsius, 100 degrees 102 degrees Fahrenheit, is more often present in hepatitis and C. A and C than in hepatitis B or E. Dark urine and clay-colored stools may be noticed by the patient from 1-5 days before the onset of clinical jaundice. With the onset of clinical jaundice, the constitutional prodromal symptoms usually diminish, but in some patients mild weight loss, 2.55 kilograms, is common and may continue during the entire icteric phase. Liver becomes enlarged and tender, inflammatory signs, and may be associated with right upper quadrant pain and discomfort. Infrequently, patients present with a cholestatic picture, suggesting extrahepatic biliary obstruction. Splenomegaly and cervical adenopathy are present in 10-20% of patients with acute hepatitis. Rarely, a few spider angiomas appear during the icteric phase and disappear during convalescence. Duration of the posticteric phase is variable, ranging to 12 weeks, and is usually more prolonged in acute hepatitis B and C. Complete clinical and biochemical recovery is to be expected 4 to 8 weeks. After the onset of jaundice in 3/4 of uncomplicated, self-limited cases of hepatitis B and C, among healthy adults, acute hepatitis B is self-limited in 95–99% while hepatitis C is self-limited in only 15%. Laboratory features: variable increase in liver enzymes during the prodromal phase and precede the rise in bilirubin level. The diagnosis of anicteric hepatitis is based on clinical features and on aminotransferase elevations. This reflects severe hepatic synthetic defect, signify extensive hepatocellular necrosis, and a diagnosis of hepatitis. This reflects severe hepatic synthetic defect, signify extensive hepatocellular necrosis, and worse prognosis. What is it? Hepatic necrosis. A diagnosis of hepatitis A is based on detection of IgM antibody during acute phase. A diagnosis of HBV infection can usually be made by detection of HBsAg in serum. The principal clinical usefulness HBsAg is as an indicator of relative infectivity. HBAg and HBV DNA are indicators of HBV replication, but tests for the latter are more sensitive and quantitative. Assays for HCV antibody tests are the most sensitive tests for HCV infection and represent the gold standard in establishing a diagnosis of hepatitis C. A patient with acute hepatitis should undergo 4 serologic tests: HBsAg, anti-HAV IgM, anti-HBC IgM, anti-HCV. Viral hepatitis, prognosis. Virtually all previously healthy patients with hepatitis A recover completely with no clinical sequelae. In acute hepatitis B, 95–99% of previously healthy adults have a favorable course and recover completely. Certain clinical and laboratory features, however, suggest a more complicated and protracted course. Patients of advanced age and with serious underlying medical disorders may have a prolonged course and are more likely to experience severe hepatitis. Initial presenting features such as ascites, peripheral edema, and symptoms of hepatic encephalopathy suggest a poorer prognosis. Hepatitis C is less severe during the acute phase than hepatitis B and is more likely to be anicteric. Fatalities are rare. Viral hepatitis, complications and sequelae. A small proportion of patients with hepatitis A experience relapsing hepatitis weeks to months after apparent recovery from acute hepatitis. Another unusual variant of acute hepatitis A is cholestatic hepatitis, characterized by protracted cholestatic jaundice and pruritus. Fulminant hepatitis, massive hepatic necrosis. Most feared complication, rare event primarily seen in hepatitis B and D, as well as hepatitis E, but rare. Fulminant cases of hepatitis A occur primarily in older adults and in persons with underlying chronic liver disease. Hepatitis B accounts for and 50% of fulminant cases. Treatment. In hepatitis B, among previously healthy adults who present with clinically apparent acute hepatitis, recovery occurs in 99%. Although severe acute hepatitis B is not an approved indication for therapy, and although the duration of therapy has not been determined, nonetheless, most authorities would recommend institution of antiviral therapy with a nucleoside analog for severe, but not mild-moderate, acute hepatitis B. In typical cases of acute hepatitis C, recovery is rare, progression to chronic hepatitis is the rule, and meta-analyses of small clinical trials suggest that antiviral therapy with interferon alpha monotherapy, 3 million units SC 3 times a week, is beneficial, reducing the rate of chronicity. A high-calorie diet is desirable, and because many patients may experience nausea late in the day, the major caloric intake is best tolerated in the morning. Hepatotoxic drugs should be avoided. Glucocorticoid therapy has no value in acute viral hepatitis. In fulminant hepatitis, the goal of therapy is to support the patient. Maintenance of fluid balance, support of circulation and respiration, control of bleeding, correction of hypoglycemia. Treatment of other complications of the comatose state in anticipation of liver regeneration and repair, protein restriction, oral lactulose or neomycin administration. Prognosis. Hepatitis A and B active immunization with vaccines is the preferable approach to prevention. Hepatitis D can be prevented by vaccinating susceptible persons with hepatitis B vaccine. Significance of, in the absence of active or passive immunization, prevention of hepatitis C includes behavior changes and precautions to limit exposures to infected persons.